This segment deals with articulations, or joints, where bones come together and interact. Two classification methods are used to categorize joints. One way to categorize joints is based on function and on the amount of movement possible between two bones. There are three functional groups. The synarthrosis is an immovable joint, which can be either fibrous or cartilaginous. This type of joint may fuse over time. A synarthrosis joint includes the sutures of the skull and the gomphosis that binds the teeth to the bony sockets in the mandible and the maxilla. These are extremely strong joints and are located where movement between the bones must be prevented. The amphiarthrosis is a slightly movable joint that is either fibrous or cartilaginous. The amphiarthrosis permits more movement than the synarthrosis, but it's much stronger than a freely movable joint. An example of an amphiarthrosis are at the pubic symphysis, where the articulating bones are separated by a wedge or a pad of fibrocartilage, and at a syndesmosis, where bones are connected by a ligament, for example, at the distal articulation between the tibia and the fibula. A diarthrosis, or a synarthrosis, is a freely movable joint. The diarthroses are subdivided by the movement that each joint allows. Diarthroses are usually located at the ends of long bones in the limbs. A monaxial synovial joint allows for movement in only one plane, like at the elbow and the ankle. A biaxial synovial joint allows movement in two planes, like the wrists and the ribs. And a triaxial joint allows movement in three planes, like the shoulder and the hip. The second way to classify joints is based on the anatomy of the joint, whether it is bony, fibrous, cartilaginous, or synovial. The two ways to classify joints are loosely correlated, but we will use the functional classification rather than the anatomical one. We'll spend most of the discussion on this segment on synovial joints. Synovial joints are freely movable and classified as diarthroses. A synovial joint is surrounded by a joint capsule, which is also called an articular capsule. Synovial fluid produced by cells in the joint capsule fills the joint cavity. Special articular cartilages cover the articulating surfaces. These articulating cartilages resemble hyaline cartilage but have no perichondrium surrounding them. The surfaces of the articular cartilages are slick and smooth and help to reduce friction during movement at the joint. Synovial fluid prevents two opposing articular cartilages from coming in contact with each other. If the articular cartilages are damaged, joint function usually can't continue as the bone matrix becomes exposed and the slick, smooth surface changes to a rough, abrasive surface. This abrasive surface increases friction at the joint. Synovial fluid resembles interstitial fluid with a high concentration of proteoglycans. Even in a large joint, such as the knee, the synovial fluid is normally less than 3 milliliters. The synovial fluid within a joint has three primary functions. It helps to lubricate the articular cartilages to reduce friction between the moving surfaces of the joint. It also contains nutrients for the chondrocytes of the articular cartilages. It also provides shock absorption to help cushion joints that are subjected to compression, such as when you jog or run. There are many accessory structures with synovial joints, including pads of cartilage or fat, ligaments, tendons, and bursa. Here we will look at a sagittal section of a knee joint. In many joints, like the knee, a meniscus may lie between opposing articular surfaces. A meniscus is a pad of fibrocartilage located between opposing bones within a synovial joint. The meniscus subdivides the synovial cavity and may allow for variations in the shapes of the articular surfaces. Fat pads are localized masses of adipose tissue that are covered by a layer of synovial membrane. These fat pads protect the articular cartilages. When the bones move, the fat pad fills in the spaces created as the joint cavity changes shape. Ligaments support, strengthen, and reinforce synovial joints. Ligaments join bone to bone. They're very strong. In a sprain, a ligament is stretched to the point where some of its collagen fibers are torn, but the ligament as a whole survives and is undamaged. A ligament tear will occur with more excessive force and will heal very slowly, as ligaments have no blood supply. Broken bones, on the other hand, heal more quickly because of their extensive blood supply. Tendons pass across or around a joint. Tendons extend from muscles and attach to bones. It doesn't limit the joint's range of motion, but it does help to stabilize the joint. For example, tendons of the shoulder help to brace the shoulder joint. The bursa are small, fluid-filled pockets in connective tissue. They contain synovial fluid and are lined by a synovial membrane. Bursa are found between a tendon or ligament and other tissues and prevent these structures from rubbing. They are mostly located around synovial joints, like the shoulder joint or the hip joint. If a bursa develops because of abnormal stresses, it is called an adventitious bursa. If a joint is highly mobile, then it cannot be very strong. The greater the range of motion at a joint, the weaker it becomes. A synarthrosis, which permits no movement, is the strongest type of joint. A diarthrosis is far weaker but permits a greater range of motion. When a skeletal muscle contracts and pulls on a tendon, movement of the joint occurs. The joint during movement may be stabilized by the shapes of the bone, the capsule, the ligaments, tendons, and muscles associated with it. When reinforcing structures can't protect a joint from extreme stresses, a dislocation may occur. In a dislocation, the articulating surfaces are forced out of position. This displacement can damage the articular cartilages, tear ligaments, or distort the joint capsule. A dislocation is extremely painful because of the sensitive pain receptors associated with the capsule, ligaments, and tendons. A subluxation is a partial dislocation and is less severe. People who are double jointed have joints that are weakly stabilized, and they are more likely to suffer partial or complete dislocations.